standard blood pressure control on mild cognitive impairment and probable dementia, which are based on the findings from the SPRINT trial. So the SPRINT trial was essentially the systolic blood pressure intervention trial. And this is just a cohort study that was like a follow-up of that trial. So a little background on this is, so dementia is a growing public health crisis with estimates suggesting that over 9 million Americans will have dementia by 2030, and this increases to nearly 12 million by 2040. So currently there is no cure, which makes prevention strategies very critical. So one promising avenue was the prevention is blood pressure control, since hypertension is a known modifiable risk factor for cognitive decline. So, more than 50% of Americans over the age of 50 have hypertension, which is a figure that is rising to about 75% by the age of 65. So, there are previous observational studies that have suggested that blood pressure management might help reduce the risk of dementia. So, this SPRINT trial was initially designed to evaluate cardiovascular outcomes, but they later expanded it to examine cognitive effects as well. So the study objectives here are, the primary objective of the study was to determine whether intensive blood pressure control targeting a systolic BP of less than 120 millimeters of mercury reduces the risk of mild cognitive impairment and probable dementia compared to the standard BP control, which targeted a systolic BP of less than 140 mmHg. So there was a secondary objective that they wanted to evaluate whether aggressively lowering the systolic BP would decrease the longer term incidence of cognitive impairment within the SPRINT cohort. So the study design was a randomized control trial with an extended observational follow-up after the trial concluded. So here the participants that were included were aged 50 years or older. They had hypertension and increased cardiovascular risk, and they were excluded if they had diabetes, a history of stroke, or polycystic kidney disease. So here they were recruited from 102 clinical sites in the United States and Puerto Rico, and they were randomized into two groups. So one was the intensive BP control with less than 120 HG, and the standard BP control of less than 140 HG. So the intervention lasted for about 3.26 years, and the follow-up was almost about, it increased from 2 years to about 7 years. So this is the timeline of the SPRINT trial. So essentially, recruitment from the 102 sites was between 2010 to 2013. And this was when all of the randomization process occurred, where they split the participants into the two treatment groups. From 2013 to 2015 is when the treatment was offered. And then from 2015, they had actually um, decided to stop the trial because they found there was a beneficial effect from their primary outcome. So essentially, the primary objective was cardiovascular event and all-cause mortality. So that was for the SPRINT trial. So since they found a beneficial effect, they decided to stop the trial in 2015, and they continued to do a period of follow-up till around 2018. And this specific study of the cohort study, the follow-up started from 2018 and lasted till 2030. I mean 2023. So this is just the randomization process that went into splitting the participants into the two treatment groups. So you can see that there was a total of 9,361 participants, and they were randomized into both the intensive group as well as the standard group. So here you can see that there were some reasons that the numbers decreased, and it was because of people either declined uh, to be in touch later, they did not attend their closeout visits, or they had just like withdrawn from the study. And there were also a certain number of people who were deceased. So since they were unable to contact them, they had like another round of ascertainment to see who would be willing to continue to be in the study. So there were also a lot of people who were excluded because of probable dementia and post randomization, but it was before this cohort study. So in the end, the number of people who were included in the final analysis were 4,280 in the intensive treatment and 4,291 in the standard treatment. So we moving on to the cognitive assessments. So the participants underwent annual cognitive testing at their follow-up visits. So some of the outcomes included mild cognitive impairment, probable dementia, and a composite outcome of both mild cognitive impairment as well as dementia. So these assessments were standardized and they were conducted by trained examiners. And these were some of the tests that were included. I also wanted to mention that for all of the tests and questionnaires, they were validated Spanish translations as well that were made available to the participants. So, um, moving on to the key results. So, the cognitive outcomes here were that the risk of mild cognitive impairment was significantly reduced in the intensive BP control group. So, they were also able to find out that the composite outcome of mild cognitive impairment along with dementia was also significantly lowered in the intensive BP control group, although there was no statistical significant reduction for participants for probable dementia alone. So these findings suggest that the early blood pressure intervention may help delay cognitive decline, but does not entirely prevent dementia. So additionally, while the intensive BP group achieved lower BP levels during the trial, there were certain differences between the two groups that diminished over time once the trial ended. So here you can see that the intensive treatment, the BP levels are relatively low compared to the standard treatment during the trial phase as well as the trial and the cohort phase. But there is a contrast once the trial ends. And during the follow-up period, you can see that the intensive treatment, the BP levels have suddenly like raised. So this was a bit concerning or just something that they wanted to point out that although the intensive BP like achieved lower BP levels during the trial, there were differences after, and they just wanted to um, kind of follow up and see why this contrast was there during the follow up. So moving on to the statistical findings. So here the primary cognitive outcome of the study was the occurrence of adjudicated all-cause probable dementia, and the secondary cognitive outcome included occurrence of adjudicated MCI and a composite outcome of occurrence of either probable dementia or MCI. So here we can see that since the um, mild cognitive impairment as well as the composite outcome, both of them had a significant reduction and they were both found to be lower in the intensive treatment group, whereas in probable dementia, it was not statistically significant, but we still saw that there was a lower dementia incidence in the intensive BP control group. So the intervention appears most effective in reducing early stage cognitive decline, but its effect on the later stages of dementia remains unclear. So the cumulative incidence of MCI and probable dementia and the composite of both outcomes was estimated separately, accounting for the competing risk of death. And interactions between the treatment group and subgroups of interest were also assessed with a likelihood ratio test. So these subgroups were, for example, age, where it was less than 75, greater than 75 years, and sex, race, education, etc. So here in the table, you can see they have mentioned from the original sprint trial and the cohort study with the follow-up. So they're mentioned as three outcomes. So probable dementia, mild cognitive impairment, and the composite outcome of mild cognitive impairment or probable dementia. So they have split the category into the both the treatment groups, and you can see the number of outcomes per person year as well as the cases per person year. And they also mentioned the hazard ratio. So here, since the probable dementia with the additional follow-up is not statistically significant, but we can see that in mild cognitive impairment as well as mild cognitive impairment, the composite outcome, both of them are statistically significant with a hazard ratio of 0.81 and 0.85 respectively. So this was just their results based on the follow-up of the original sprint trial. This is the graph that they had mentioned where, so essentially the graph on the left shows the original report and the one on the right shows the follow-up. So here the blue line indicates the standard control group where it was the lesser intensive BP, and the red line indicates the intensive arm. So here from the trial and cohort phase, they do not overlap for individual participants, but because of some randomization over time, there's an overlap in the trial and cohort phase for the trial population when the time is measured relative to the date of randomization. So here the trial phase encompasses the follow-up through the end of study closeout visits. So here you can clearly see that in the follow-up group, the level of the intensive BP group is much higher. I mean, it's lower than the standard, but it just continues to increase after the follow-up period compared to like the original report. So moving on to the strengths and limitations of the long-term follow-up study. So some of the strengths were that it was a large and well-defined cohort, and it included participants of high cardiovascular risk. The randomized control trial design provides a strong causal evidence of the control effects of BP. There's real world applicability because hypertension is a common condition in older adults, and long term observation follow up adds additional insights beyond the trial period. Some of the limitations are that the trial ended early due to the cardiovascular benefits, which limited their long-term follow-up. The study did not include individuals with type 2 diabetes, prevalent stroke, or advanced kidney disease, which limited its generalizability. Some cognitive assessments were telephone-based, which could potentially affect the accuracy of them. Dementia often develops over a longer period of time than the study duration. So this could possibly lead to underreporting. Blood pressure differences between groups decreased over time after the trial ended, which weakened the long-term conclusion. And there was also a loss to follow-up. Even though it was similar in both of the groups, it could lead to under-ascertainment of cognitive outcomes. So next is the strengths and limitations of the strength of the sprint study population. So the strengths are that it was a diverse, high-risk population, and it makes findings applicable to hypertensive individuals at cardiovascular risk. It's a rigorous randomization and intervention protocol, ensured that there was a high quality of data. Limitations were that they excluded patients with diabetes and stroke. It limits the applicability of findings to the full hypertensive population. The study focused on older adults, making it unclear if findings applied to younger adults. And follow-up relied on only the available participants, which could introduce potential survivor bias. So the clinical implications and future directions. So the implications for clinical practice would be that um, controlling the blood pressure could serve as an early intervention strategy to slow cognitive decline, and hypertension management should be considered for beyond cardiovascular benefits in order to include cognitive health. Um, and the future research needed here would be that the longer term studies to assess the sustained cognitive benefits of BP control, identifying optimal BP targets for dementia prevention, and exploring alternative cognitive assessment methods in order to improve the accuracy of the diagnosis. Um, so in conclusion, intensive blood pressure control significantly reduces the risk of mild cognitive impairment and cognitive decline. However, its effect on dementia alone remains unconfirmed, suggesting that more research is needed. These findings support aggressive blood pressure management as a potential strategy for preserving cognitive health. However, long-term follow-up studies are necessary in order to determine whether these effects persist over time. Thank you. And we can move on to the Q&A session and maybe a time of discussion. These are some questions that I thought would be good to have a discussion about.
Sounds great. Whenever you're ready, you can head into the questions.
Okay. Yeah, so one of the questions that I was thinking about was how, should hypertension guidelines be revised in order to also emphasize cognitive health? So I was looking into some of the research that they had already mentioned and maybe some of the articles that they reference, and they had never talked about how in a trial they would have to also take into consideration cognitive health. They would just talk about how they would try to reduce hypertension or work on diabetes of like a patient. So I think this was a this was an eye-opening like trial to see that okay, that there are long-term effects of doing things like this, and it could also relate to like cognitive assessment. So I was just wanting to like see if anyone had any views on that or had any opinions or suggestions.
Maybe we can start with some pros and cons of assessing them with cognitive health.
Mhm. Um, so from what I um like looked into, I think it was just uh one moment, I'm just looking through my notes. Um, mm,
I
so I
don't,
think
I
oh,
think
sorry, you can go ahead. Yeah.
we have a comment from the main room. We can't hear you if you guys are trying to talk. I think you're muted right now. You weren't for a while, but now you're muted. You can go, Michelle, while they're figuring out the
Okay.
part.
Okay. No, I was just going to mention that since there since the prevalence of dementia is just increasing and there's maybe like a lack of an actual cure, obviously one of the critical prevention strategies would be like managing VP. So I think we definitely need to know more. We definitely need to know more research in order to actually establish like an optimal target and like see what it would be like in cognitive assessment, like specifically for the benefit of like a cognitive um, part. So I think before we formally like revise guidelines, we would probably have to do more research in order to see like what can be considered as a range that they would be looking into for like management. I think someone in the room wanted to say something.
I believe so.
Yeah.
Hello, can you hear us?
Yes, we can hear you now.
Can you hear me?
Yes, yes,
All right.
doctor.
Hi. Is there an echo or is this okay?
This is okay.
Okay, great, great. Yeah, we're having a little bit of audio difficulties here. So, yeah, I actually just mentioned that, first of all, apologize for being a few minutes late because I couldn't find the room. So I was just gonna, I mean, this is I think one of the best done studies, but there are many other studies, or several others. Most of them had limitations. Is there a meta-analysis, systematic review of trials on this topic that could guide us? I guess maybe I'm asking a question that I already know. There is. Okay. And
Yes.
yeah. So there's actually a set of guideline. There's a guideline committee of the American Heart Association that's actually meeting now to revise and update the guidelines that were done in 2017. So I think this is one of the topics that they're going to cover. I was wondering, before you talk about the guidelines, are there, I chair the DSMB that stopped the trial. So I have some insights on what happened and why. And but I could also take myself back about 12 years ago when this trial was first, when we had to review the protocol. And I think there's something that people should be aware of, which is that the primary outcome is an outlet of cardiovascular disease, outcome, stroke, heart attacks, et cetera. And all of those outcomes that were part of the composite have very short lag periods. It's just about a lag period of about 1 year before a blood pressure intervention can show its effect. But the part of the reason SPRINT was designed was for this, to answer this question, which I thought was perhaps the most important question that had to be resolved. But its lag period, is actually pretty long between the point at which intervention is implemented and you actually can see effect. I mean, because cognitive decline reflects sort of a degenerative process similar to kidney disease and heart failure. So those outcomes, well, except for heart failure, can take a long period of time. So my question is 3 years roughly of an experimental contrast long enough to give to I guess answer this question? And a second issue, is this the right population for it? And I'm not sure you covered this earlier, but a lot of people believe that cognitive decline starts in middle age, and that by the time people reach their 70s and 80s, the horse has been out of the barn for about 20 years. Okay, so I just raise those issues, which I think are really important to the interpretation of this study.
Thank you so much for your feedback on that. Yes, I was looking into some of the articles that were talking about like when they think that cognitive decline occurs or when they think that the onset of dementia occurs. So there were a lot of articles that talked about how it ranges from about like 3 to 7 years prior to like cognitive impairment, or like dementia diagnosis could happen between like 1 to 11 years, which is crazy because when the entire trial was only about like 7 years, or like the follow-up was 5 years, the fact that they were already able to come to an a kind of a result saying that this is statistically significant, which is kind of like maybe undercutting the population as well, because if it actually takes about like 7 years to even figure out that this is what's happening, by essentially cutting down the trial time and essentially terminating the trial earlier, you're kind of also um, not including all of the people that could be at risk of maybe the cognitive impairment or of probable dementia. And you just lose a lot of people that could be included in your study, and you could actually have more statistical significant results. So yeah, that I think that goes well with like the next question where we were talking about how does early trial termination affect the reliability of these findings. So one thing that I was seeing is that yeah, because of this long-term follow-up, and they were, since the original SPRINT trial had early termination, it obviously limited the long-term follow-up. And yeah, I think that even though it was an RCT and it like supports its findings, and it was able to, like, because of a rigorous study design, it was able to talk like well about early cognitive decline. But I think another aspect was that since participants were kind of aware of the trial ending, they could have also been like, this could have also influenced their behavior like post trial. I don't know if that maybe made a lot of effect, but I think that was maybe something to look into as well.
One thing you could do, I mean, could you go to the figure with the blood pressure contrast? Because I think that actually is a really interesting figure for several reasons, where it was figure 3, I believe.
Yes.
Yes, this
Yes.
one.
Yeah.
Okay. So this, why is the trial terminated? Well, the trial was terminated because, in large part, because they said, well, the result needs to go out, but it's also for, because participants, particularly those in the concern was the control group, that they should get the benefit of potentially lower blood pressure. And it wasn't as much what the active treatment was going to get. So, but what do you see in this figure? You see that the control group had very steady blood pressure, and the change that occurred after the DSMB or the intervention was stopped, you actually have a rise in blood pressure, which is not what any of the investigators or the DSMB sort of anticipated, and certainly was not the logic behind terminating the trial. This is actually very disappointing, because when a DSMB stops a trial, they usually do it because, or one of the thoughts, and maybe not the only one, is that the control group, or the group that had an inferior assignment, should be given the intervention. So when you just mentioned the behavior that people might have had after learning that the trial was beneficial, these results don't suggest that there was any behavior that you would anticipate. The group that had the best benefit in terms of cardiovascular disease prevention had a rise in blood pressure, almost close to what to the control group, got. Sorry if I have a long-winded response, but it's one of the most striking figures. It's in a supplement, but it's one of the most striking figures that comes out of the SPRINT trial from my perspective. Maybe that's my bias, because I was the DSMB chair.
No, but I do understand when you think that the intensive treatment and it's been consistently showing results of maybe being better than the standard care, and then suddenly once the trial ends, it kind of goes haywire, or you just don't expect it to suddenly like drastically increase.
I can just tell you that when the trial ended and the results were published, there were numerous people that said, why did you wait this long? We should get these results out so that, the benefit, so that we will change that people in the trial should get the intensive, the benefit of lower blood pressure, that guidelines should change immediately. And it was a striking sort of response. It was even in a New York Times editorial. But what happened actually was just the opposite. The intensive group, despite having, improved risk or a reduced risk, actually their blood pressure got worse. That's the big change.
Mhm.
Well, what caused it probably is that, a clinical trial creates an experimental contrast where none exist. And when you take away that intervention, if it's not rapidly picked up by the clinical community, there should be this recidivism back to standard. So this is as much an indictment of our healthcare delivery system about not being able to move as fast as you would think. Now, I can just tell you that both of these groups were given letters to share with their personal doctors about the benefits. So even the providers, who had had participants in this study, evidently didn't. It wasn't convincing enough. I'm not quite sure why. I personally think that a blood pressure goal of less than 120 is highly desirable, but this wasn't good enough, I guess.
I'd like to ask a follow-up question, if I could.
Yes.
Any thoughts about whether that is more because clinicians either were unaware of or didn't agree with that goal, or is it really hard to achieve that goal? And did the careful construction in the context of the trial achieve something that is just impossible to achieve or very difficult to achieve in the clinical setting?
Yeah.
Like, did participants come back frequently to get their blood pressures checked and their medicines tweaked and things that the clinical system is just not set up to do, sadly, if that's the case.
Yeah. So your points are well taken, Dave. So I did another trial that was very similar to this. And it takes a good amount of effort to achieve a blood pressure of less than 120 systolic. But once you get there, it's easy to maintain. And most clinicians, most people who are involved in these trials realize this, that yes, it takes some work to get there. But that's not what explains this, because these people, could have just continued their regimen of medications and probably done well.
That's
But
true.
your point about was it accepted, there was debate, and I was a bit surprised by the amount of debate. So geriatricians, have this mindset that it's not just preventing stroke and heart attacks, but people get dizzy, lightheaded, and there's some consequences. So I think a lot of geriatricians would love to be able to back off on blood pressure treatment. And so certain subgroups of professional societies have not accepted a 120 goal, yet the American Heart Association and the American College of Cardiology have accepted a lower blood pressure goal than 140. Many are not accepting 120, but 130 or so. So I think you're right on both accounts, Dave.
Interesting.
Yeah. So here's a methodologic quirk that nobody would pick up. So was the outcome where people masked to the outcome? Were the data, was the team that was obtaining the data, adjudicating the data, masked to intervention assignment? You can go to the papers. It's actually not as well described as you would think.
Yes, that was what I was gonna also mention. I think we had discussed some questions about masking, and when I was looking through the trial, it doesn't specify necessarily if they were blinded or if there was any masking that was occurring behind the scenes that we didn't know about. I think they have not been explicit about that.
Yeah. Well, I always think of masking as a process, not and it involves several steps. So I think in one of the papers, at least, they do indicate that the adjudicators were masked. But I can tell you on the DSMB, there's a lot of discussion because this, even though it's like many studies or trials, they're expensive. And most of the clinical sites did not actually have masked data collection for the cognitive outcomes. And this was a big discussion item on the DSMB. In the end, the steering committee recognized the value of it, there just was not the money to have separate staff collecting cognitive information on cognitive function by mass collectors. So it's an issue. This is not like a biomarker like weight that could be, it's highly precise and you're not as much worried about it. But as you probably, I actually don't fully understand the adjudication process for mild cognitive impairment, but it does involve, administration of questionnaires. So same people that were doing the intervention were also doing some of the event or the data collection for cognitive dysfunction in the study. It was done, it wasn't done uniformly from what I recall, but that was a concern when we were when we were involved with review of the protocol.
One of the other limitations that was discussed in the paper was about how they had used like mostly like telephone-based cognitive assessment procedures rather than like an in-person assessment. So I think they had specified that when they couldn't reach out to a participant or they couldn't get their assessment, they basically relied on like a proxy respondent. So I was thinking, how do you think this response of a proxy would maybe like affect the overall like um results or like the follow-up procedures, because it could have introduced like a bias, but I'm not sure if a telephone-based assessment is maybe the frequency, or maybe it was just a lot to handle, I guess, when you have to like follow up with like that large number of participants.
Yeah. Yeah, I think I believe that the telephone interviews were a substitute for in-person, and you need to think of it in two phases, sort of pre-COVID and during COVID. So pre-COVID, yes, there were some people that weren't coming in and they did it by telephone, but I believe during that, and when you look at this graph, the cohort phase, that overlapped a lot with the COVID pandemic. And so this was one of several trials which had to have outcome, data collection done remotely. And in this case, telephone ascertainment of cognitive decline or cognitive function. So if you look, I think it's in one of the supplements. They can't really do, the extensive battery that they would do in person. So I think it's probably it probably introduces imprecision to the estimate. Now that would mostly affect, of course, MCI, mild cognitive. Dementia, I think most people would think that dementia is more robust and less likely to be influenced by these, it's likely to be more high specificity. I guess that's the way. But the problem, I mean, where we saw the benefit though was with MCI at both time points. So I do think that overall it probably is okay, but I think that if you had a better instrument, you probably would get a more striking result.
We can maybe visit the other discussion questions as well. So one was, what alternative cognitive assessment methods do you think could improve the accuracy of the research? Another was, what are potential risks of this intensive control of the blood pressure in older adults? And another one was, what factors might explain the lack of a significant dementia reduction despite the benefits that we see in mild cognitive impairment?
Michelle, are you asking for folks to address any of these or any specific one?
Yeah, I mean, I mean, the floor is open to any question. Maybe just like any thoughts that they have on any of the remaining discussion points, I guess.
Right.
I can fill the void. What are the potential risks? So if you go to the first paper that was published in New England Journal around 2015, it does go over some of the adverse, the usual sort of serious adverse events, but also other medical problems that could be caused by the treatment. So one of the areas of concern, as I mentioned earlier, was sort of dizziness / syncope as a concern, and there was slightly more in the intensive group. And then a second one has to do with what they call electrolyte abnormalities, changes in blood potassium and actually sodium levels, which tended to occur more in the intensive group. So there are some risks, but one of the things that is that and again, this has been a discussion about cognitive decline. One of the more striking features of the primary results paper is that it reduced total mortality, and there are not too many trials of any type that have reduced total mortality. So, there are these potential risks. Some of them, it's very symptom oriented, like dizziness, but that was a huge factor in terminating the trial. A reduction in total mortality from an intensive blood pressure goal. So it's this weighing that's very complex, of course, but there are some risks, but there are some striking benefits.
Was the early termination the result of a pre-specified guideline or requirement, or was it more of just an evaluation of accumulating risks and benefits?
Oh, it was, we had, I forget Fleming O'Brien, is it? We had boundaries that we are tracking with pre-specified time points. And I still remember it was May of 2015 when the boundary for benefit was just barely crossed. And at the same time, it was deemed that there was like a nearly significant or maybe slightly significant benefit for total mortality. But there were some quirks. There was a lot of unadjudicated events that had occurred. And then there was some disagreement or ambiguity about one of the parameters that went into that function. And so what the DSMB did was to have an urgent meeting 3 months later in August. And at that point, the boundaries were definitively crossed for the primary outcome. Total mortality was significantly reduced. And that was the point at which the trial was, the recommendation of the DSMB was to, it was fun. It was not to end the trial. It was to notify the participants, and then the NHLBI and the other funders had to decide whether to continue the intervention or not, and they decided not to. But anyways, there's a whole cascade of things that happen.
Yeah.
And just as another, it actually was really, it's quite interesting. I mean, most of the DSMB really wanted to continue the intervention, actually, maybe in the active intervention group, and let the control group go back to the primary care providers for care. And that would have been a much better design than what happened, because as Michelle pointed out, we're reporting on the outcome data, but the intervention had stopped after just 2.5, 3 years on average. So we're looking at, effects over 10 years, 7 years removed from an active intervention period that lasted only 3 months. My sense, I actually wrote a letter to the Institute directors making a strong recommendation to continue active intervention in the intensive group, but they didn't accept that. And so we left with somewhat of an ambiguous result in the end.
Any additional comments or so?
Michelle, I think I sent you the letter that I had sent to you can distribute that, because I think it's like a nice postscript.
Okay.
I think it's one of the biggest errors that the directors at NHLBI made. They've made some errors, but that one was, I think, they could have had I mean, it's a landmark study, but the landmark issue is cognitive decline. Most of us believe that the cardiovascular outcome was going to be beneficial, and so that's what it was. But the big unresolved issue has been cognitive decline, and does intensive blood pressure control, prevent cognitive decline, dementia.
Would you like me to maybe share the letter as well, or just circulate it in the email?
So you can do whatever you want. I don't have any. It's an interesting letter. I look back at it, and it's one of the, it was the DSMB. As I said, our role was safety, and so we did our job and effectively terminated the study. But everybody really wanted, or on the DSMB wanted, the continuation of the intervention. And so I drafted a letter and submitted it to the directors of NHLBI, NIA. But it wasn't enough for them to change their minds. So they just stopped the intervention. They did have the follow-up assessments, but it would have been a much better study if they had continued the intervention. Yeah.
I've just shared the I just presented the letter so that everyone can see, but I can also email it to Dr. Ann so that she can circulate it to everyone.
Thanks, Michelle. We can probably post it on the Course Plus website as well.
Okay.
Yeah.
Any final comments or questions? If not, we can end a couple minutes early. All right. Thank you, everyone, for joining. It was a great article. Good choice. We will see you in a couple weeks. Take care.
Bye-bye.
Yep. Bye.
Thank you.